Very warm welcome to our person-centered complex care theme meeting. I hope you're able to attend the earlier session where Taj Nathan gave a great overview of the work that's going on in the theme, highlighting really quite a large number of projects that are coming through, and also highlighted the three core areas that we'll be working on following a lot of consultation with members and the public. And just to remind you, they are around multimorbidity, continuity of care, and digital healthcare. And one of the things that I need to highlight is that we've got a workshop set up around continuity and integration of care, so that we can kind of drill down and further develop some focus, so that we can start pulling together probably some project or even program grants to try and address that area. And that workshop is going to be happening on the 20th of October at 1:30. We'll put something in the chat, but it'd be great for you to come and join us, because it's a really important area for us to start to tackle. And I think that's highlighted to an extent in the agenda for our meeting today. And what we've got is 4 presentations. We're going to start off with 2 slightly longer presentations, which discuss projects, rather large projects that have been funded. One's a program grant, and one is a national program of work around mortality in learning disability. After those 2 presentations, there'll be a short break, and I'll introduce the next 2, which are two projects which we'll be asking you to indicate your views about whether they're a priority for our theme. One's around dementia and discharge planning, again very relevant to our coordination and integration of care, and the other is around using data and collecting data to improve care. And again, that's if we haven't got the information to help inform our decisions around coordinating care, then we're in trouble. So I guess at a high level they seem immediately relevant, but it'd be good to get your feedback on all of that. So I realize that my talking is eating into time, so I'm going to stop so that we can get on with the first 2 presentations.
Thank you for asking me to give a presentation. I'm going to tell you about heart failure and its relationship to kidney function. Heart failure is a condition where the heart fails to supply the required amount of blood and oxygen to the body's organs. This results in various symptoms, including tiredness, breathlessness, particularly on any exertion, swelling of ankles, sometimes of the legs, rapid heart rate, which can cause palpitations, and cough, which occurs particularly when there's fluid on the lungs. The good news is that there have been significant advances with the development of many new drugs over the last decade or so, which have improved the prognosis of people living with heart failure and improved survival. Kidney function is intimately related to heart function, and heart failure is frequently associated with impairment of kidney function. Somebody who has got normal kidney function has a glomerular filtration rate, that is GFR, which is greater than 90. As kidney function deteriorates, it goes through various stages, as you can see here, ending up at stage 5, which is the glomerular filtration rate of less than 15, which is when people need dialysis. Fortunately, very few people get to the stage of dialysis, but as we get older, our kidney function does deteriorate, and this deterioration may be made worse by pre-existing disease, including heart failure. Now, heart failure affects kidney function through 2 different processes. The first is disease process itself. If your heart failure is poorly controlled, that can affect your kidney function because not enough blood is getting to the kidneys. The second area is that diseases that cause both heart and kidney failure may be the same, for example, atherosclerosis or hypertension. Another area which is where we've been particularly interested in is to look at the effect of medicines which are used to treat heart failure. These medicines can sometimes cause side effects or adverse drug reactions, which can lead to kidney impairment. They may also worsen pre-existing kidney impairment. We did a study many years ago which showed that the second commonest reason for why patients were admitted to hospital because of side effects or adverse drug reactions was because they had kidney impairment secondary to the drugs which are used to treat their heart failure. Now, there's simple ways to be able to prevent this. One is by undertaking simple blood tests, which can pick up the change in kidney function. However, there are no guidelines on how often blood tests should be done. And more importantly, what should be done when an abnormality in your blood test is found. This unfortunately leads to huge variation in clinical practice, sometimes resulting in people living with heart failure being admitted to hospital with kidney failure. This shows data from electronic database, which shows that there's great variation in clinical practice on how often kidney tests are done. First of all, if you look at the bottom line here, in most cases, very few kidney tests are done or 0 kidney tests. But even in the individuals who do have kidney tests during this 1 year, you can see there's quite a lot of variation with the number of tests varying from 0 to over 15. And this variation persists irrespective of how long you've had heart failure. So we've just been awarded an NIHR program grant for £2.5 million. And the aims of this are twofold. The first is to generate guidelines for personalized renal function monitoring based on evidence. What I mean by that is that we want to personalize how often you need to have your kidney test done depending on the severity of a disease. So if you have quite severe heart failure, you may need your kidney test done more frequently than if you have less severe heart failure. More importantly, what do you do when you find that the kidney function is declining? What are the optimal interventions in terms of changing drugs, reducing dose, or just literally basic checking your kidney function more frequently? We hypothesize that implementing this care pathway will improve the quality of life and reduce the number of hospitalizations due to drug-induced renal injury in people living with heart failure. Our program grant builds on work which has been undertaken in the Northwest Clark. It was called the Permit Project, and many of you participated in that, and thank you very much for your participation. This work also resulted in the award of a PhD to Dr. Ahmed Al-Nair, and the work we're continuing is following on from Ahmed's PhD. This diagram shows you what we're going to do in this program grant. It's called Renal HF, and there are 5 work packages. The first work package is to develop an algorithm using electronic health records to predict when heart failure patients require renal function monitoring to prevent kidney injury. These are the personalized renal function monitoring schemes I talked about before. Work package 2 is the co-creation of clinical pathway. We may develop the algorithms, but if it doesn't fit in with the way clinical practice works in GP practices, it won't work at all. So we're going to work with the primary care team, GPs, pharmacists, nurses, to be able to co-create this clinical pathway. Importantly, we're also going to have input from specialists in heart failure, specialists in kidney failure, so we can develop the guidance that is required when you see that your heart failure is affecting your kidney function. Once we've developed the pathway and the algorithm, we'll need to test it to make sure it works. We're going to do this by undertaking a randomized controlled trial. That is, we will have some practices which will implement the algorithm, while other practices will not, and they will serve as comparators. As part of this, in work package 4, we will also look at the cost effectiveness to make sure that this is not costing the NHS too much. Very important part of all this is work package 5, and that is the patient and public involvement and engagement. This encompasses all the work packages that you see in front of you. We intend to do this over a 5-year period in order to come out with something that can be used clinically in the NHS. really important part of the work we've undertaken so far, as well as the work we'll undertake over the next 5 years, is the patient-public involvement and engagement. And I want to pay tribute to Lynn Hedgecoe, who was a co-applicant on the grant and helped us with developing the program grant, as well as all the participants who worked with us on the permit project and hopefully will work with us as we move on to this program grant. We think that PPIE is crucial to the whole program, and we have an extensive package of activities and support for the engagement and involvement of patients and public throughout the program. And hopefully you can work with us, and thank you for your participation, and thank you for listening to this talk. I'm happy to take questions. I'm sorry I can't be here with you, but please send me an email with any questions. I'm happy to answer that. Thank you very much for your attention.
Thank you very much, and hello everyone. My name is Umesh Chauhan. I'm Professor of Primary Care at University of Central Lancashire. I also work as a GP in East Lancashire, and I'm the Quality and CBD Lead at East Lancs CCG. I'm going to provide you with a brief overview of the Learning Disability and Autism programme, which some of you may be aware of already. This was established and funded by NHS England back in 2015 and has up to now been delivered by University of Bristol. The aim of the programme is to reduce inequality in care of people with learning disability and autism by reviewing deaths that occur either in the community or within a hospital setting. UCLAN is part of a consortium led by King's College London that's been successful in this bid. The other partners involved include King's College University and St George's University of London. This is just a mugshot of all the folk who are involved in putting the bid together. I'm afraid Richard's picture is covered over by me. There are three elements of the programme. We'll be analysing data from all the deaths that occur and producing an annual report. We'll also be undertaking 2 deep dives a year, and I'll give you some more details about this in a few minutes. And we'll be looking at evidence of emerging themes that might be of interest for us to explore in more detail by undertaking a rapid review of the evidence. For example, what's been happening over the last few months around deaths related to COVID. So we've set up a steering group that will consist of Professor Andre Stridham as the chair and a number of other colleagues, some of who are yet to be appointed. There's a co-production group led by Professor Irena Duffrey-Winya, which includes people with learning disability, experts by lived experience, and there's an advisory board that will oversee the programme. There are a number of stakeholders and experts who are part of this bid, and this includes Pathways Associates and Innovation Agency, both at the Northwest Coast as well as in London. The co-production element is quite important, and we've ensured there's a significant element of input, and that will include Pathways Associates and Janice in the Northwest, but Richard Keegan-Bull and Irena will have access to a number of folk with lived experience in London. I think it's important to highlight this element, and we're keen to develop this further locally as well. And this is just a quote from Richard that's worth sharing. So in terms of the leader data analysis, there is a process that we're currently undertaking in terms of agreeing what we will take forward in terms of analysing data over 2022. The analysis will make sure that there's consultation with the relevant groups and stakeholders as well as experts, and then we'll produce the reports in easy read as well as relevant to commissioners. The deep dives are an important element of developing quality improvement methods, and we'll be using both qualitative and quantitative data. We'll appoint or have experts panels linked in with steering groups, and we'll have topic experts. So for example, we've already identified constipation as a significant problem that causes unnecessary morbidity and mortality in this group. And we'll be looking into this in more detail. An important element that I think it'd be useful to get the ARC involved with would be around the service improvement, where we want to look at how we can potentially improve quality by undertaking quality improvement cycles. And I think I'd like to be able to come back to you guys and be able to share potential ideas of trying to, or ways of trying to improve care for people with learning disability. There is additional added value in terms of trying to expand capacity into research and quality improvement for people with learning disability and autism, and this will include providing exposure to students through masters and PhD programs, and training co-researchers, people with lived experience. I'm sure folk will have additional questions. So if they do want to contact me, I'm more than happy to be contacted and discuss in more detail. But this is just a brief overview of the programme. Thank you.
That's great. So hopefully there are two projects which I think to an extent highlight the breadth of the PCCC theme as and also highlight some of the complexity. So our next two presentations are projects which we've been working up through the theme, and it's time to work out whether members and the public think that they are addressing a priority such that they should be further supported, and an additional ARC resources spent on working them up further. We may have a couple of technical gremlins, but at the moment the plan is that you'll see the first presentation, then we'll ask you to vote and prioritize, then we'll do the second presentation and then ask you to prioritize. But if there's a problem with the voting and prioritization, we may need to go for a plan B, but that's virtual life. So the first presentation is from Taj Nathan, who you met earlier in the first session, and he's going to discuss a project he's been working up around really a coordination of care project around hospital discharges for patients with dementia who've been admitted to hospital with dementia or other medical problem. Okay, so.
Hello, I'm Taj Nathan. I'm a forensic psychiatrist and director of research at CWP. Thanks for the opportunity to present our proposal at this meeting. As should be clear from the title here, the proposal relates to our plan to develop a care bundle for patients with dementia discharged from acute inpatient settings. Just quickly to mention the others in the team, the idea began with Steve Callahan and Rosie Whittington, who've been involved in the delivery and commissioning of relevant services. And from their knowledge of this clinical area, they could see that it may be possible to introduce some fairly routine clinical actions that may have positive outcomes for patients living with dementia who find themselves in acute inpatient settings. I became involved when Steve and Rosie approached the trust where I work as Director of Research, and that trust is CWP, to pull together a group of stakeholders to explore the ideas further. Dr. Andrea Brown is a higher trainee in psychiatry who has taken a lead on reviewing the literature and writing the proposal. And finally in the list there, Prof. Steve Jones from University of Chester became involved due to his experience of overseeing clinically relevant research. So just to provide some background, we know that there are discrepancies in the outcomes of patients in acute hospital settings between those living with dementia and those who are not living with dementia. For example, patients living with dementia have prolonged hospital stays and higher rates of readmission shortly after discharge. So the point is, with an increasingly aging population and the likely associated increased prevalence of dementia, coupled with their disproportionate representation in medical inpatient populations, it's critically important that health providers try to address factors that account for the disparity in outcomes. Just saying a bit about care bundles there. It's a term that's used to describe a limited and clear number of interventions which are thought to optimise care delivery. And there's evidence for the clinical utility and effectiveness of care bundles in other clinical settings. But there isn't the evidence of care bundles and the utility and the effectiveness of care bundles for patients living with dementia who are discharged from acute care, and that is what we would like to develop with a view to improving outcomes. So we've already held an initial consultation with representatives from different providers, and from that consultation there was unanimous support for the idea of this sort of care bundle. We've undertaken a review of the literature and found that although there is empirical evidence in favour of care bundles in other settings, there's little empirical evidence that would inform the specific type of care bundle we are thinking of. So our current plan is to use the Delphi technique to develop a care bundle, and I'll say a bit more about that in the next slide. And then we would like to pilot the care bundle that emerges from that Delphi technique in order to test its utility and clinical acceptability before then, and most importantly, undertaking a funded trial of its effectiveness. So here I've set out the stages of the Delphi technique, and I'm not going to labour this point. We're adhering to the accepted format for the Delphi technique, but it involves getting together a panel of experts, having ethical approval to involve those experts, and then presenting open-ended questions to the panel with regard to what may produce positive outcomes, such as reducing lengths of stay, prolonging periods in the community following discharge, and reducing the length of subsequent admissions to hospital. The panel then consider this information and rank the suggested interventions, and then from that a care bundle is designed. So final slide here is to make the case for collaborating with the ARC. Firstly, we believe, the team believes, that it would enhance our proposal through the links we hope we can make with academics who have expertise relevant to this area of clinical practice, and to those academics with methodological expertise in the area of intervention development, intervention of this sort, particularly with regard to the use of the Delphi technique. Secondly, we believe that it provides ARC with an opportunity to work in close collaboration with providers and clinical academics in the development of innovative practice that is a priority to services and patients, and that has immediate clinical application. And thirdly, we believe that it will be mutually beneficial to our group and to ARC if we can collaborate following the development of the care bundle to apply for funds to undertake an empirical evaluation of the care bundle. So if this application is approved, then we would want to enter into discussion with ARC to understand how this collaboration may be of mutual benefit by getting into the detail of what additional expertise such a collaboration would bring. Okay, I'm grateful for you listening to this talk, and I hope you feel able to support it.
Okay, that's hopefully that was clear. I don't think Taj is able to join us today, so I don't think we've got an opportunity to have any Q&A. So it'd be helpful to share the poll now to just give you an opportunity to give a view about whether you think this is a priority, a sort of area that the person-centered complex care theme and ARC should be focusing on, and then secondly, whether this is something that would be of interest to your organization. So we'll just slightly quiet and twiddle our thumbs for a few seconds whilst you have the opportunity to vote.
Just a note on the polls. Once you have selected your answer, please click the submit button to submit the answer. Please don't forget to click submit.
Sorry, if I can just also add, when you are prioritizing this proposal for ARC, you would be prioritizing it on on behalf of your member organization. And if you do that, we would appreciate if you could go to your member organization and mention that you have prioritized it. Thank you.
So how are we doing? Have we got lots of votes in? I can't see a counter or a ticker anywhere.
Just give us a few more seconds.
Yeah, okay. How's that, Peter?
Yeah, thank you. Voting is complete.
Super. Thanks, everyone. Okay, right, and so we'll now move on to a second project. Hedley Emsley, who's a neurologist up in Preston and Lancaster, professor of neuroscience up there, and project around using data to improve delivery of care. So are we ready to run Hedley's presentation, please?
Many thanks for this opportunity to present the project Neurology Informatics to Improve Patient Care. I'm Professor Hedley Emsley, consultant neurologist at Lancashire Teaching Hospitals and Professor of Clinical Neuroscience at Lancaster University. I work closely on this theme with Professor Joe Knight, who's a Professor of Applied Data Science at Lancaster University. We have inadequate neurology informatics to deliver the necessary improvements in patient care. The lack of accurate data means we can't tell whether services and treatments are leading to improved outcomes or the extent to which health and care systems are meeting patients' needs. And there are significant missed opportunities to deliver research in this field. Data and intelligence have clearly supported rapid advances in cancer and stroke care in the past decade in particular, but we need robust clinician engagement to ensure we have accurate data. And then this can be a robust basis for a range of applications, including benchmarking, standard setting, service and workforce planning, and so on. And of course, better data will also provide a robust platform for research. We've done some work in this area. Joe Knight and myself have been supervising Fran Biggin, a PhD student working on a neurology outpatient data set, and she's unearthed significant variation in waiting times by diagnostic category. She looks at routine data from new NHS appointments at a single consultant delivered clinic between September 2016 and January 2019, based on data I'd recorded prospectively. Working diagnosis was assigned live in clinic and recorded in the database, and then data was linked to the hospital administrative data with all the relevant permissions, including ethics. Combined data with assignment of diagnostic categories based on working diagnoses were used for the analyses, and she found that 5 diagnostic categories accounted for 62% of all patients, with headache most common. Waiting times varied substantially, 65% of patients with seizure or epilepsy were seen within 18 weeks, but only 38% of patients with a movement disorder, such as Parkinson's disease, were seen within 18 weeks. This figure shows two dotted vertical lines representing 2 weeks and 18 weeks after referral. The headache part of the figure shows that many patients are seen early, as are some of the seizure patients. That will be driven in part by suspected central nervous system cancer and first fit pathways. But of course, many patients with movement disorders are seen quite late. We need to sort out the diagnostic coding for neurology outpatients, as there is currently no standardized system. And we've been working on this with the Neuroscience Advisory Group nationally, and now have a standardized scheme pretty much agreed for implementation. And we're hoping that that will move forward swiftly now. This will facilitate research. Coding is expected to form the backbone of the neurology informatics work and can be linked to clinical outcomes. It enables us to build condition-specific registries, and we really need rapid implementation for a number of reasons. Lancashire Teaching Hospitals has moved to a trusted research environment built with Microsoft Azure, which will include existing data sources and can be enriched with population health data from a range of partner organisations. We have local agreements for the Neurology Service to be one of the first users of the TRE. This figure depicts the outline of the TRE, which can take in structured and unstructured data, and illustrates the various processes that happen within it. An exercise has started to identify existing neurology data assets and to acquire the relevant metadata, and this will give us a better understanding of the range of data sets and necessary data linkages and applications. Diagnostic coding data will be key, and existing and future condition-specific data assets can then be imported to the TRE. Late onset epilepsy represents a good example, with cases being identified through diagnostic coding. We expect the clinical phenotyping to populate condition-specific database within the TRE with linkage to other relevant primary care data sets. And this will pave the way for powerful large-scale analyses, particularly if a regional or wider approach is taken. And this work absolutely addresses health inequalities. There's robust evidence of health inequalities affecting patients with neurological conditions, particularly in the Northwest Coast region. Late onset epilepsy is a good exemplar, and there's an excess risk of cerebrovascular and neurodegenerative disease. PPI work revealed that late onset epilepsy is certainly perceived to be a neglected area of research, and the participants said they would look favorably upon the use of routine data, particularly as this reduces participant burden. There are significant additional opportunities, including potential to work with Health Data Research UK, the Neurological Alliance, and existing work with Public Health England, soon to be the Office for Health Improvement and Disparities. And there is a current project on neurological emergency admissions that we're working on, which is showing relationships with social deprivation. The ARC can help in a number of ways. We would welcome suggestions. We particularly value analyst time, and that could support a range of elements of work within this theme. So many thanks for your time.
Great. So hopefully another clear presentation. Obviously, then quite a different project to the previous one. So hopefully you've got in front of you your opportunity again to highlight whether you think this sort of projects are one to prioritise for ARC, and whether it's something that your organisation would want to be involved with. And I will also remind you to press the submit button once you have made your choices. So we'll just go quiet for a minute whilst you have the opportunity to think about it and select your choices. That's great. So we have almost filled our 40-minute slot. I will again remind you about our continuity of care workshop, 20th of October, 1:30. Pallavi will be circulating a link for that fairly soon. And I think I will now draw this meeting to a close and give you the opportunity to navigate your way to the next session. So thanks for attending, and see you next time.